We're going to talk about the MRI lecture today. So, MRI or magnetic resonance imaging is a non-invasive, usually painless, depending on the patient's pain level, medical test that helps doctors diagnose and treat medical conditions. MRI is kind of the baby when it comes to diagnostic imaging. It's relatively new. I know when you guys find out the year, you won't think that's necessarily new, but in the grand scheme of things, MRI is kind of the baby. So MRI is known as MR or MRI. It's kind of used a little bit interchangeably. MRI stands for magnetic resonance imaging, or MR just stands for magnetic resonance. So MRI imaging uses a very powerful magnetic field, and then it also uses radio waves and a computer to help produce the detailed pictures. And we can see organs, soft tissue, bone, and virtually really any other internal structure. One of the major benefits to MRI is that unlike general x-rays or CT imaging, MR does not use x-ray radiation. MR provides exquisite images with excellent contrast detail of the soft tissue and any anatomical structures, like the gray and white matter in the brain or small metastatic lesions or cancers in the liver. And then MRA is magnetic resonance angiography. So we use X-ray angiography a lot for imaging the blood vessels, but with X-ray angiography, it's very labor intensive. It requires a lot of contrast, very large amounts of contrast, and we use radiation. So with MRA, we can get some of those same results without using the radiation or the large amounts of contrast. We still will use some contrast, but just not as much. So the history of MRI is essentially the basic principles of MRI, like the spinning action effect, was first discovered in 1945. However, they weren't using it in any medical capacity at that time. Medical applications were not really found until the 1970s. And in 1977, that's when the first MRI scans were being done. And they were taking about 5 hours to complete. So this machine is actually so old it's and considered a part of history. It's now in the Smithsonian Institute on display. So in 1984, MRI was first cleared for clinical use. So if you're ever asked what year MRI was first cleared for clinical use, the answer would be 1984. So as you can see, this is the newest modality out of all of the ones that we've talked about so far. But today there's over approximately 40,000 MR scanners worldwide and about 30,000 being sold each year. So MRI is becoming instrumental in the diagnostic imaging departments. So how does MRI work? Well, MRI, like I said before, uses magnetic energy, and it also uses radio waves to help create cross-sectional images or slices of the human body, like we talked about in CT. So it's very similar in the imaging planes to that. So the main components of MRI systems are a large tube-shaped or cylindrical magnet. It's very, very large, and I'll go into the sizes a little bit later. So the MRI uses those powerful magnets, which produce a strong magnetic field that help focus the protons that are in our body to align with that magnetic field. Then when a radio frequency current is pulsed or turned on and off through the patient, the protons are stimulated and spin out of balance. So then when that radio frequency is turned off, the MRI scanners are able to detect that energy that's released from those protons, and then it realigns them with the magnetic field. So there's kind of a lot of in-depth explanation to how MRI works. So to obtain an MRI image, a patient's placed inside the large magnet, and they have to remain really still during the imaging process to not cause any blurring or what we call motion artifact. They do use a contrast agent, usually it's gadolinium is what it's called. It may be given to the patient through an IV to increase the speed at which those protons realign with the magnetic field, because the faster those protons realign, the better the image is going to be. So during the exam, a radio signal is turned off and on. When it does this, the energy is absorbed by different atoms in the body and is echoed or reflected back out of the body. So these echoes are continuously measured by the MR scanner, and a digital computer reconstructs those echoes into the imaging of the body. So with that being said, an MRI machine, if you haven't been in one, if you've had an MRI, then you know, an MR machine is really loud and it makes a lot of different noises. Most patients are going to wear earplugs or even headphones over the earplugs. And a lot of facilities will play music through the headphones to kind of help drown out the noise. But the tapping that you're actually hearing during that sorry, I can't talk, during that MR exam is created when the gradient coils are switched on and off to kind of help measure that signal that's reflecting back out of the patient. So I'll talk about the gradient coils just a little bit more in a later slide. But the strength of the MRI system's magnetic field is measured in a magnetic or metric unit called a Tesla. So you'll hear the word Tesla quite often when they're referring to the MRI scanner. So most cylindrical magnets have a strength of between 0.5 to 1.5 Tesla. And most open magnets have a strength between 0.1 and 0.35 Tesla. And just to give you a little bit of reference, a 1.5 Tesla MR system has a magnetic field 30,000 times stronger than the pull of gravity on the Earth's surface. Now, this kind of information is a little bit older, and a lot of scanners now in the hospitals are up to 3 Tesla. So that's becoming a little bit more common. So the stronger the Tesla, the faster the scanning and the better image quality that you're going to receive. So the patient aperture or bore or opening, like we talked about in CT, of that magnet is usually about 55 to 65 centimeters wide, which is between 21 and 25 inches. And when you think about it, you think, well, that doesn't sound too small, but the table lies within that opening too, which is taking up some of that space, and then the patient lies on top of that. So we'll see in some of the later images, you can see how much space that table actually takes out. So some patients can suffer from claustrophobia and may not be able to tolerate an MRI in a typical cylindrical, or what we call a closed MRI scanner. There are some different scanners out there that we'll talk about later too. What the a traditional cylindrical is called a closed bore. We also have open bores and wide bore scanners. So, like I said, approximately 3% of MRI patients can suffer from claustrophobia. The one thing that we can do is we can pre-medicate them prior to the exam, give them something like Valium to help them relax. That way they might be able to lay a little bit more still during that exam. So keeping on with how MRI works, to begin the exam, the patient lies on a special table, like I talked about, and is positioned inside that MRI opening or the aperture or bore, whatever term you want to choose to use, where that magnet or magnetic field is created by the magnet. So that big cylindrical magnet, the table slides all the way into so that the body part is in that magnet to be able to image it. Each MR exam is made up a series of two to six sequences usually, and each sequence lasts about 2 to 15 minutes. So during that time, during each sequence, they'll tell the patient to hold nice and still, and then in between the sequence, they'll allow them to, move slightly or take a little bit of a rest before they start the next sequence. So a lot of times, if you've had an MRI, like what they would do is scan a little bit, and then they might stop and say, "How are you doing? Are you doing okay? Or if you're doing okay, we'll keep going," and they'll go through the next sequence. So what a sequence is it's actually a collection of data that yields a specific image orientation or a specific type of image appearance like contrast. So common sequences we use are like T1 and T2 weighted scans, and I'll show you those in just a little bit too. So with all the different sequences that we use, a typical exam can last from about 10 minutes to up to 1 hour. It's going to depend on the type of exam that's being ran and the MR system being used. Remember, the bigger Tesla scanners are going to scan a little bit quicker. So these are some of the coils that are used in MRI. This one is for the head, this one's for the knee, this one is for, can be the spine, the chest. There's one over here for the shoulder. The thing with coils are they're designed for each body part, and it fits like a frame over that body part that's being scanned. Because not every MR exam is the same, each is specialized to scan the area that you're having imaged. And then they have special coils that are used for each type of scan. So a coil is actually going to help the MRI machine gather that high quality images of the body part. It's essential in generating the images. If there's no coil used, there's no images. Because the radio frequency is transmitted into your body, and then the coil acts kind of like an antenna to receive the radio frequency signal that's coming back out of your body. And then what it does is it transmits that data to a computer, which then generates the images. I've had students in the past tell me that, well, I had an MRI and I didn't have a coil. Well, there's no way that's possible because, like I said, if there's no coil, there's no images. But while some of these coils are very obvious, there are some that you might not even realize. So, like a spine coil, the patients can lay on top of them, so it's not something that's covering you. But talk about claustrophobia. I mean, if you've got a patient who's already claustrophobic and they're getting a head exam, I don't know if any of you are claustrophobic. I'm not. And I've had an MRI scan and they've put this coil over my head and it was really hard to deal with that. I'm blind without my glasses, so I mean, taking my glasses off definitely helped because I just kind of closed my eyes. But if you were someone who did struggle with claustrophobia, that would be a huge issue. I have a friend that can't even ride in an elevator, so there's no way she'd be able to get the MRI done with that coil over her head. But again, like I said, I mean, sometimes if patients are really struggling, they can give them Valium to help relax them. So MRIs use very strong, good computers that allow us to create many different images. So by simply changing exam parameters, we can change the appearance of the tissues in the body on these computers. Like I said before, most sequences that we use are T1 and T2 weighted images. So T1 is used for anatomical imaging, and T2 is used for pathological imaging. And I'll break those down too just a little bit later. So this is a gradient magnet that's inside of the MRI machine. These are in all MRI machines, and they're varying strengths, and they allow us to image different body parts. The main thing to know is that the magnetic field is always on. So it's really important to ensure safety measures even when the scanner's not being used. So most of the time, MRIs are not done 24 hours a day. I mean, it maybe in some larger institutions they are, but they're usually scheduled procedures that are done, you know, throughout the day and early evening. So at that point, the magnet's still on even when there's no one there. So it's really important that anybody that has access to an MRI room knows all of the safety protocols. The pertinence to the medical community is one, it's non-invasive, which is always a good thing. And MRI is one of the best diagnostic exams for imaging many different types of soft tissue. So that's a huge positive. Some of the downfalls is that it's expensive. It's one of the most expensive exams in diagnostic imaging, and most of them require a pre-approval from your insurance before they will do the scan. Another issue can be claustrophobia. Like I said, about 3% of patients are have claustrophobia, sorry, or claustrophobic. And then there's the limited patient population. If someone has metal in their body or some other medical issues that would require them to not be allowed an MRI scanner. And we'll go over those too in just a little bit. So MRI provides excellent evaluation of neural anatomy, like our brain, vessels in the brain, eyes, and inner ear. It's also great at visualizing the spine, cardiac anatomy, like our heart, aorta, and the coronary arteries. It's great at looking at the musculoskeletal system, including our joints, shoulders, knees, wrists, ankles, and feet. And a lot of times when we're looking at these areas, especially if they're looking for a tear, a lot of times they will join with fluoroscopy and they'll do an MRI arthrogram. I don't know if you remember the arthrograms we talked about in fluoroscopy, where they would inject a needle into the joint space and they would fill it with contrast prior to the MRI. That way, when they scan them in MRI, there would already be contrast in that joint, and we would be able to see if there was a tear much easier. It's actually hard to diagnose a tear on an MRI without the contrast in the joint. It also provides excellent evaluation of the pelvis, hips, and the male and female reproductive organs, the upper abdomen, liver, kidney, spleen, and pancreas, and vascular structures. Like I said before, MRI is magnetic resonance angiography, and it is very good at visualizing the blood vessels without using radiation or a large amount of contrast. So, with that being said, there are limitations to MRI. So, high quality images can only be assured if the patient is able to remain perfectly still. So, that can be a problem if we have patients who are confused, like dementia, if they're anxious or in pain. If someone's in pain, it's going to be really hard for them to lie still. So, those can all be limitations for the scan. Breathing is a limitation. Breathing can cause motion artifacts or image distortion. So, like some of our motion is involuntary, right? Our heart, we can't hold our breath through the entire scan. Remember, I told you that it was 10 minutes to, an hour, depending on the exam. So, you can't hold your breath for that entire thing. So, lung movement, and then our bowel movement, not having a bowel movement, but bowel motion, is involuntary. So that can be a source of the emotion artifact in an abdomen or pelvis scan. A person who's obese might not fit in the opening. Remember, like I said, it depends, but between 25 and 21 inches. So, that's from the table up. So what we do a lot of times is we do what is called a dry fit. If a patient is large and we're not sure if they will fit, then we'll bring them into the scanner area and we'll lay them on the table and see if they can fit in there prior to the scan. Because we don't want them to go through that whole process and do everything that they would need to do, especially if it's an arthrogram. We don't want to put that patient through that whole procedure, put an injection and fill their shoulder with contrast just to find out that they don't fit in the MRI, because that whole other part would be pointless. Some facilities have actual inflatable like rings, and it's the actual size of the scanner, so they can put it around the patient to see if they would fit without them having to go into the MRI room to do it. The presence of implants or other metallic objects can make it difficult to obtain a clear image. So metal kind of shows up as a black hole on MRI. So that's a little bit different than CT. If you remember some of the artifacts on CT, metal, like a filling in the tooth, it was like starburst pattern. It was like striations. But in MRI, it just kind of looks like a big black hole. Metal makes it hard for the MR system to kind of tune to your body. So, like, think of it as like blocking the signal. So, when you're trying to tune into a radio and there's something blocking it, you're not able to get that station in. It kind of does the same thing. So, there will be no signal, so it'll just look like a big black hole. Another limitation is assessment of the lungs. So, there's really low photon density in the lungs, and the photons are what we align so that we can visualize things. So that's a reason. And also, you get that motion artifact from the lungs and the heart. So they usually don't use MRI to assess the lungs. Pregnancy can be a limitation, although there's no real reason to believe that MRI harms the fetus. The effects of MRI are still unknown. It's not. It is a newer modality, so it's going to depend on the facility. So, some facilities they'll do MRIs on women who are over 12 weeks pregnant. Some facilities, the pregnancy doesn't matter, but they won't use contrast if a woman's pregnant. So, like I said, it's going to just depend. But if you're asked on this for reference, it would be um, under 12 weeks, you would not scan for MRI. Some of the other limitations are um, MRI may not always be able to distinguish between tumor tissue and edema fluid. So it also can't detect calcium that's present in a tumor. So those are some limitations on that. And then the cost. MRI typically costs more and may take more time to perform than other imaging modalities. So that being said, MRI is not good for trauma or emergency patients. Because if we want to get a scan fast, so like for head trauma, for example, we're going to send that patient to CT. That scan time is going to be much faster. We'll get the results and we can start treating the patient. Well, we don't want the patient laying on our MRI table for 30 minutes if we think they might have trauma or like a brain bleed or something like that. So, like I said, MRI is not really good when it comes to trauma or emergency patients. Some of the benefits for MRI. It's not invasive. I talked about that earlier. There's no radiation, which is great. The MRI detail is a invaluable tool in early diagnosis and evaluation of many different types of lesions and tumors. One of the great things about MRI is it can show both the structure and the function of the organs and how they're working. MRI is great at detecting abnormalities that may be obscured by bone on other modalities, like ultrasound. Remember, ultrasound can't penetrate bone, so that's going to be an issue. MRI allows the doctor to assess the biliary system non-invasively and without contrast injection. So a lot of times prior to MRI, to look at the biliary system, they would have to go into surgery and they'd have to inject contrast in there to be able to visualize anything. So MRI gives them the ability to do that without surgery or contrast. MRI provides fast, non-invasive alternative to X-ray angiography for diagnosing problems of the heart without radiation or large amounts of contrast. So even though MRI is slow, it's still faster than having to go through that whole angiography procedure. MRI contrast is less likely to produce an allergic reaction than the iodine-based contrast that we use in CT or X-ray. So with all the good benefits, talking about the risks, MRI poses almost no risk to the average patient as long as all the safety guidelines are being followed. So, there are issues with metal in MRI. There are mistakes that can be made. If we're following those safety guidelines, the patient will be safe. There are times where those guidelines weren't followed. There was actually a story of an 8-year-old boy who was killed in an MRI scanner because someone brought in a normal oxygen tank into the MRI unit and it actually pulled the oxygen tank into the scanner and killed the little boy. Now, um, there are specific oxygen tanks that are MRI safe. Someone didn't know, wasn't trained properly, and brought that oxygen tank in with the patient. Now, MRI has MRI safe fire extinguishers that are safe to bring in there, oxygen tanks, wheelchairs, stretchers, all of those things that are made out of a non-metallic metal like aluminum. So they can bring those in safely without injuring anyone. So if sedation is used, there is a risk of excessive sedation. I mean, obviously we don't want to over-sedate the patient, so that's a risk. The contrast that we use is a very, very different contrast than what was used in X-ray or CT. It's non-ionic, so there's a much lower chance of an allergic reaction from that injection. And again, like I said, while the magnetic field is not harmful itself, medical devices that contain metal can cause serious injuries to patients, and it's happened. So, MRI contraindications for exams are just metal objects. Um, we go through a detailed history of things or reasons why patients can't have scans, and I'll go through those a little bit more. But essentially, the contraindications are metal objects, and first 12 weeks of pregnancy. We wouldn't scan the patient. One of the big benefits of MRI is that it can easily acquire different views of the body in almost any orientation. So in CT, we can scan in the sagittal, coronal, and axial planes. But in MRI, we can scan in all of those planes and an oblique plane. And the great thing about being able to scan in an oblique plane is, for things like ligaments and muscles that aren't going to run in those normal sagittal or coronal planes. So oblique opens up a whole new option to be able to see different anatomy. CT scanners, like I said, typically acquire images perpendicular to the long axis of the body, but MRI can scan in almost any orientation. So these are the three of the main imaging planes. So this is an axial MRI. So it's looking at the brain from below in a series of images that start at the chin and then move up towards the top of the head. A sagittal MRI looks at the brain from the side. It starts at one ear and then moves to the other side. And then a coronal MRI looks at the brain from behind, starting at the back of the head and then moving towards the face. So these are your three standard planes, like I said, that you have in CT as well. But then you've got some additional planes here too. So you've got some oblique planes that we can do, which is going to give you a different perspective of the image. So it opens up a whole new, area to image. So the machine itself, they've got three typical designs. There is a couple more, but they're not very common. Um, so we've got an open bore, a closed bore, and a wide bore. I'll show you some pictures of them in just a minute. So traditionally, MRI scanners have had about a 23.6-inch bore or opening. Like I said before, most closed bores run between 21 and 25 inches. But because of this, a lot of patients have reported being claustrophobic, or others are just unable to fit in them. So a lot of companies started making open bore scanners to accommodate these patients. But the problem with the open bore scanners was they started to sacrifice image quality. So then manufacturers started producing these wide bore scanners. These scanners have about a 27.6-inch bore or opening. So kind of opened it up just a little bit more. There's a slight image quality loss between closed and wide bore scanners, but it's still much better quality than the open bore, because open bore scanners actually have a weaker magnet. So just for a little bit of reference, an open scanner uses about 0.3 Tesla to 0.7 Tesla, and a closed bore uses about 1.5 Tesla to about 3.0 or 3 Tesla. So the high magnet strength can improve the image quality due to the increased signal strength. So the higher Tesla, the better your image quality is going to be. So to kind of break them down into sections, the closed bore is the traditional MRI scanner. You have a quicker scan time than open bore. But the problem with that is it can cause claustrophobia, and there's limited space for the larger patients, and they can be loud. The open bore is great for larger patients or pediatric patients. A lot of times what they'll do with pediatric patients is instead of sedating them, they'll have the patient's parents stay right there with them inside of the scanner. They're not being scanned themselves, but it gives the pediatric patient a little bit of comfort. So they're more open for claustrophobic patients. The problem is, because they're a weaker magnet, they have a longer scan time and lower scanning resolution, but they are quieter. So then going back up to the wide bore, you have the same image quality as traditional, maybe a little less, but you have better quality and it's faster than the open bore. Scan times are going to be the same as the traditional, but you have a larger bore and it can fit larger patients, and it's still going to be loud. So when I show you the pictures of some of the different ones, like here, okay, so here's closed, open, wide, and an open bore. So here's the thing. Now this is a closed bore. You've got your opening from here to here. Now, if patients are claustrophobic, that can really bother them, but it depends on what they're doing. With the open bore, it's open on the sides, but there's still something right above your face. So some people with claustrophobia, they struggle with having anything close to their face. So this might still be a problem. When you go to the wide bore, what it does is it opens it up a little bit more, so you have more space above your face. So it's going to depend on what bothers the patient, but these are the three different scanners. And you can see here, here's a closed bore and another closed bore. Remember I said that opening is about, 23.6 inches on average, but you've got the table that's going in there too, which is taking up the bottom portion of this bore. So then you've only got from the table to the top for the patient to fit. It's really not that much room. And then you've got the wide or large bore. Look at how much room is between this woman and the top of the bore. So if someone's claustrophobic, it may still bug them to go inside, but it's going to give them a lot more space above them. And again, another wide bore. This patient's actually laying on a coil, so that's why it's bringing her a little bit closer to the top. And this is an open bore. See, this one's not even truly open on the sides. Most of them are open all the way, but it gives them a little bit more space in there to make them feel like you're not so closed off, but it's still really close to the top of their body. And here's another open bore where it's truly open on the sides. So I guess that helps with people's peripheral vision if it's something that's bothering them. So it's really important to keep metal away from the scanner. Remember, the magnet is always on. We never shut it off. So we've got to make sure that we're adhering to safety protocols to keep anything away from the scanner. So here's some accidents that you might see, and I'm going to try to show you some videos too if I can get them. So this is an IV pole. So that, as you can see here, the IV pole is down here with all of the stuff on it. It was actually sucked into the magnet there. When I worked at Chelsea Hospital, when they were redoing, or maybe they were doing something to the MRI unit, I don't remember, but a maintenance worker brought in a step stool to do some work in there, and it yanked the step stool into the scanner. Luckily, it was after hours, so there wasn't anybody in there, but still can cause severe damage to the scanners, and depending on how strong the magnetic pull is, that can cause a big problem. Like I said, that magnet's always on, and to completely shut everything down, they have to do what's called a quench, and that's going to release all of the gas out of the MRI unit, and it essentially it costs like $500,000 to get that fixed if you have to completely quench or emergency shut that MRI down. This is a pallet jack, which is, if you can see here, there's a pallet on wheels that they were bringing heavy material in that was pulled into the MRI scanner. And this is a regular bed that is not MRI rated safe. Imagine if a patient was on that bed. And look at how, it lifted it right off the floor and it's pulled it in there and it's kind of crumpled it just a little bit. It's very scary, and it's why it's really important to take the proper precautions and be safe. I don't know, magnetic eyelashes is something that's becoming a little bit more of a trend. Maybe it's going to phase out, I'm not sure. But I had a student in the past ask me about them, so I've added this video in. Give me just a second here, I'll pull it up. So here's what would happen in an MRI if you had magnetic eyelashes on. So they've got a mannequin with magnetic eyelashes, and this here, there's just a barrier to stop it from actually going into the magnet. So as it starts to advance into the bore, or the opening, you start to see the pull on the magnet, on the eyelashes. See them move just a little, and then they're going to rip right off. So those are just magnetic eyelashes. I mean, that can cause damage to the patient. It can hurt them by ripping off their eyelids. I'm going to go ahead and pause this for just a second here. I've got a couple other videos. This one actually is kind of going back to that little kid with the oxygen tank. So they've got this magnetic object, the oxygen tank, and see how he's kind of holding it there, and it's actually the magnetic field further away is pulling it. Now, this shows you that the second you walk into the room, it's not going to pull it into you. It's going to depend on the strength of the magnet. I mean, they're fairly close, but they're holding this here, but then, and they've got a watermelon in the head coil down there. When they start to push it in, as it gets closer to the magnet, see how it's slow-mo. So that's the danger of bringing something into the MRI room that's not approved. So they're trying to pull right now that oxygen tank off of there, and they really can't. They're going to go back behind here and kind of show you what happened, where it flew out the back. It's really scary, you know, to think about people just making a simple mistake and how it can affect, you know, the patient that's laying on that table. One last quick video I'll show you here, just a couple other things that they kind of get close to the scanner, like a washer, I believe, and a stapler. See how it bounces continuously in there and then takes a place on the magnet? So, you know, if something goes in there, it's not just hitting the patient. You know, think about if someone's body part is in there.
So the force we're reading on that guy right now, just at that part
I'm not going to have you watch the rest of this. This
close to 300, 280?
Yeah, just kind of, they're showing you the pull. So I just wanted to show you some of those videos just to kind of give you an idea of, you know, what the possibilities are of, you know, dangers in MRI. So the most frequent exams that we do are head and spine, the head and spine exams. And it lists here the T1 and T2 weighted exams. So I kind of talked about these a little bit before, and I'll break them down in the next slide. But we scan the head, and we'll do it in a T1 or T2 scan, and the fluid on a T1 is going to look dark, and the fluid on a T2 is going to look white or bright. And we do that for both the head and the spinal cord. So T1 and T2 images. T1 is going to show the anatomy, such as ligaments, bone, muscles. So we want to use this sequence if we're looking for like a ACL tear in the knee or a rotator cuff tear in the shoulder. T2 weighted images are going to show pathology better. So they'll show bruising, infections, or mass, things like that. So we're going to use the sequence based on what we're trying to visualize for that image or that scan that we're doing. So the T1 weighted images, in these images, the water contains structures that are dark. So most pathology that we're trying to image contains water. So T1 weighted images don't show good contrast between normal and abnormal tissues. However, they're going to show the anatomic detail really well. So you can see all the different folds of the brain, you can see the skull. If you're looking for just strictly anatomy, that's what we're going to go for. But then the T2 weighted images, the water is bright on these. So T2 weighted images provide excellent contrast between the normal and abnormal tissues because it shows pathology. So the anatomic detail is less. See, you're not seeing such a good definitive definition of the brain and all the folds, but we can see if there's pathology. So that's what is important to know the difference, is what we're trying to visualize. So again, T1 versus T2 images. So the T1 shows the anatomy. So you can see all the great folds in the brain here. And fluid looks dark. So you can see that there's fluid in here, right? Because it's dark. And then T2 weighted images are going to show the pathology, and the fluid is going to be bright. So you can see, look at the difference in being able to see this tumor on the T2 weighted image versus the T1. I mean, yes, you can see it's there, but you're getting much more image quality for the pathology in this one. And you can see here too kind of how they have the lines drawn and how the fluid is dark on the T1 and then it's bright on the T2. So MRI and MRA, we do use contrast, but it's not the same as X-ray. I already said that before. It's non-ionic. It's not ISOView. So gadolinium is the contrast that we use in MRI. I would remember that name, gadolinium. We use it by injecting it through an IV. So gadolinium has very little side effects, not like ionic contrast, and a very slight risk of an allergic reaction. Gadolinium is a highly magnetic mineral. It's non-iodine, and it's actually made of a silvery white metal. So MRI uses the contrast in specific cases to kind of alter the frequency given off by the tissues, and in some cases it can help detect pathology. So as you can see kind of here from this next slide, this is a T1 weighted MRI with no contrast. You can kind of see some things going on in here. But on the T1 with contrast, look at how it kind of lights it up. So you can see there's definitely something going on there. So this is a single brain metastasis, so it's metastasized from breast cancer. So that patient had breast cancer and then it spread into the brain. So that's why it's important sometimes to use contrast depending on what we're looking for. So again, here we have a scan that is pre-gadolinium. You can't see those two spots really well at all. And then when they put the gadolinium in, you've got a mass here and a mass here. Preparations for an MRI. Technically, there's none prior to coming into the hospital that day. So in a lot of the other modalities we talk about, the patient has to be NPO or, they have to fast or maybe they have to drink water. When it comes to prep like that, really there isn't any with MRI. The biggest thing would be if a patient's claustrophobic, they're going to need to take that sedative or Valium or whatever that is the doctor prescribed for them probably at least 30 minutes prior to the scan time for it to take effect. If they wait to take that till they're in the MRI room, it's not going to take effect while they're laying on the table. So we need to let it work before that. Patient prep at the facility would be they need to change into a gown, and a lot of times we give them scrub pants because they're in there for a longer period of time. We want to make sure they're covered and warm, depending on what we're imaging. But to change them out of their clothes, it's going to allow imaging free from any types of artifacts that could be caused by the fabric of the clothes they're wearing, any zippers or buttons that they might have on there. The patient's going to need to remove all jewelry, if they have a watch on, any earrings, necklace, etc. They need to remove their hairpins or clips that they have in their hair. And actually, there was a woman one time who forgot to pull out a hairpin from her hair, and the hairpin actually was pulled by the magnet up her nose, and then it was actually lodged into her pharynx, and she had to have surgery. So it's really important to make sure that you get all those. Patients also need to remove any keys, coins, wallets, or credit cards. Most of the time, if they're taking their pants off, those things are going to be in their pants, but it's still something you need to go over with them. And credit cards are really important because, all your credit cards have those magnetic strips on the back that we swipe. Well, MRI will actually demagnetize that strip and your credit cards won't work anymore. I've known a lot of MRI techs who accidentally left their credit card or debit card in their scrub pocket because they just went to the cafeteria and forgot about it, and then they had to get a new debit card. It's the same with badges. If you work at a hospital where they have swipe access on your badge, if you wear your badge into the MRI scanner, it will wipe that clean and you won't be able to use your badge access anymore. So most MRI techs have two badges, one that they wear all the time that's demagnetized, and then the other one they use to gain access to things. Other things that need to be removed: eyeglasses, hearing aids, any removable dental work, belts, buckles, anything like that. So pretty much everything needs to come off, and they can put on the gown and change that way. So information needed prior to the MRI scan. Any patients that are undergoing an MRI must fill out a very detailed patient questionnaire prior to going into the MRI scanner. So, a lot of times when you register at the front with the secretary, they're going to give you this large questionnaire to fill out, and it has to be done prior to going in because there's a lot of things that can be very dangerous for an MRI scan. So it's the technologist's responsibility to interview that patient prior and go through everything. So there's some specific questions that you might be asked. Um, do you have any objects implanted in your body, such as an artificial hip? Um, that's something that we need to be aware of. Now, just because they have a artificial hip doesn't mean we can't scan them. A lot of them are titanium. So after the body's had time to heal and there's scar tissue around them, usually about 6 weeks, we can scan them in MRI as long as the metal's safe. But a lot of times we'll do x-rays prior to verify. Some of the other questions, do you have a heart pacemaker? The device function may be altered by that strong magnetic field. So those are things that we need to make sure that they're aware of. Do you have a portacath? Some caths are fine for 3.0 Teslas or lower. Some are metal and they're not MRI safe. So a lot of times what we have to do is ask them, try to figure out what kind they are. And in MRI, they actually have a safe book that they can look up, and it will have serial numbers and different manufacturers to know whether it's rated or not. Do you have a artificial heart valve? Some scanners it's okay. Some it's only okay up to 1.5 Tesla. Do you have an intrauterine device, an IUD? So it's kind of controversial. They used to be a little bit more on the fence about it because a 1.5 or a 3 Tesla could heat them up. Now they're considered more safe. Do you have a joint replacement or anything in the bone other than something that's battery operated? Do you have metal plates, pins, or screws in your body? Do you have any surgical staples or aneurysm clips in your body? Sometimes what it can do is it can heat up the coils. It can cause heating, or it can cause them to move just a little bit. Now, if you've got an aneurysm clip in there, you don't want them to move at all or cause any damage from that. Do you have permanent eyeliner or a tattoo? Both of those things can cause artifacts. Um, the tattoos can cause bleeding if they're fairly new, or they can cause heating or burning. Anything that's new is going to be worse, and the darker the tattoo is, the worse it's going to feel. So, like those big, thick tribal tattoos, that's like just really thick black ink, those can get hot and like almost burn the skin. Pacemaker leads also can result in heating like that. We want to ask patients, do you have a bullet wound or ever been hit by shrapnel? Because if that's close to certain anatomy, again, it can heat up, it can move. The other question we ask is, have you ever worked with metal or get possible metal fragments in your eyes? If there's a possibility that a patient may have a metal fragment in their eye and we scan them, it could pull and move and heat up and cause permanent damage. So, a lot of times, what we'll do is we'll do an x ray prior to the MRI of their orbits to make sure that there's no metal in there. And the same thing can be done with other areas, to try to um, check to see if there's metal in there. So, like I said, patients with implanted metal devices or other metal in their body that is susceptible to MRI's magnetic field may not get an MRI scan. So, like I said, there is some metal that's safe. There are some things that are safe, and I think now that MRI is becoming bigger, they're trying to manufacture things that are going to be safe to allow the patient to have an MRI scan. If metal is suspected, they can use X-ray to determine if a MR is allowed. And it's really hard sometimes because you can ask patients, have you ever had metal in your eyes? Nope. I mean, I've had patients before that I've been X-raying, and I'm like, there's a little round metal ball on their face. I had one time right in the cheek area. And I went back out and asked the patient, I'm like, have you ever been shot with a BB gun in your face? And they were like, what? And he is like looking at me all crazy. And then all of a sudden he goes, oh my God, yeah, when I was a kid. He goes, I didn't know it went in there. He's like, I just thought it bounced off. But he had a BB in his cheek that had been under his skin the whole time. He never even knew it was there. So that does happen. But again, no magnetic objects are allowed in MRI due to that strong magnetic pull, like you saw on those videos. There really isn't any side effects, again, as long as, we're being safe and, contrast, things like that. There's really no true side effects to MRI. The patient perspective is most of the time it's easy. It can be uncomfortable for laying still for that long or having that coil on top of you. Discomfort from the IV for the contrast. If patients are claustrophobic, it can bother them. And the exams are long, so you can't move. And if the patient's in pain, it's going to be hard for them to lay still, especially patients who have like back pain. It can be hard for them to lay flat on that table for a while. The cost is very expensive. Okay, so remember when I was talking about x-rays that were like, $80 to $200? Now, MRIs are $2,000 to $4,000. So they're one of the most expensive modalities right now. They usually require pre-approval, like I told you that for the insurance companies. If you don't get pre-approval, your insurance might not pay for it, and some facilities won't even do it without pre-approval. Who performs an MRI? A registered radiographer performs an MRI, and it's the same thing as everything else that I've talked about. You go through go through X-ray school first, become a registered radiographer, and then you're going to either do on-the-job training or a pathway in MRI, and then you can sit for your board exam. So the initials after you pass your board exam for MRI would be RT for registered technologist, R for radiology, and MR for magnetic resonance. Technologist perspective is, it can be routine, and it's not going to be for everybody. MRI has less hands-on exposure with your patients. I mean, you take them into the room, you get them on the table, you talk to them, you put the coils over them, you ask them, all your questions, get them all set up, and then you sit behind the scanner with no interaction with the patient for the majority of the time. So, I mean, if it's a 45-minute scan, you're sitting there behind that computer for the majority of that time. So, it's going to depend on the type of person you are. It's routine. You sit for long periods of time. The images are amazing. They're really interesting. So, I love looking at the MRI images. You might have to, cope with people, long procedures, if the questions that you have to ask, there can be a lot of irritation from patients. Obviously, working in any hospital setting can be depressing and risky if you're starting IVs. Career advancement's going to be the same as all the rest of them. The team leader, manager, sales, and education. Compensation, again, is going to depend on where you live, how long you've been doing this, and your credentials. But the average is about $33 an hour. So MRI does get paid a good portion more than the other modalities. MRI ethical issues, there really are none because, like I said, you have to become that registered radiographer first and then go into MRI. That's, definitely helps with the ethical issues. Actually, I kind of not lied, I guess, but you don't always have to be a registered radiographer first. I've actually worked with MRI techs that were nuclear medicine techs prior. And I've also worked with some MRI techs that didn't do anything prior. There is a program out there, I believe, that you can do MRI without actually going through any of the other modalities first. So the future of the modality is 3D virtual reality, larger Tesla scanners. So remember, right now I said, the average is lower, but really the average is like 1.5 to 3 Teslas. 10 Tesla scanners and even higher are coming out. Some of the other future is better software, which can give us faster scan times and maybe even the possibility of doing MRIs of the lungs. But like I said, I mean, the modality is still technically in its baby stages or infancy stage. 1984 is relatively new when it comes to medical technology in diagnostic imaging. So the possibilities are really unknown and endless right now. All right, I'm going to stop this one right here before I move on to the image side of things. So I'll break this one up into two different voiceovers since this one's a little bit longer.